How's it going, guys? 2-month-old newborn boy, bilious vomiting, poor feeding, born at term, vaginal delivery. He passed meconium first 24 hours. The abdominal x-ray showing dilated loops of small bowel there, fluid levels, very buzzy for SBO, small bowel obstruction. It is non-specific, and you will see this across NBME exams for a variety of things, so you need to know that's what it means, SBO. For example, they can give you a patient post-surgery 20 years later who has adhesions, and they'll tell you dilated loops of small bowel with higher fluid levels. Okay, so it's buzzy. Upper GI series is shown. What's most likely explanation for the patient's presentation? Choice A, abnormal gut rotation, correct answer. Diagnosis, congenital midgut volvulus. And what is going to go down on USMLE is that they're going to give you a 12-line bullshit paragraph. You're going to have no idea what's going on. They're going to tell you in the last line, upper GI series was performed. Answer, midgut volvulus, because we do an upper GI series to diagnose midgut volvulus, and it's not going to show up on USMLE for anything else. Now, the image is apparently showing us a corkscrew appearing small bowel, and the USMLE will show you a very similar image here. Now, embryologically, something obscure about failure of gut rotation 270 degrees counterclockwise around the superior mesenteric artery. Now, midgut volvulus is usually the first few months of life. It can present very similarly to intussusception, intermittent bringing the legs to the chest, crying, intermittent vomiting, intermittent blood in the stool. So it sounds like intussusception, but volvulus, first few months of life, intussusception, 6 to 36 months. Volvulus, no mass, intussusception, classically a mass. There's many tangential points we can make. Not all intussusception questions have to mention the right lower quadrant sausage-shaped mass, but if they list volvulus and intussusception next to each other and they say there's no mass, it's volvulus. If they say there's a mass, there's intussusception. If they go out of their way to say that there's no mass, but volvulus isn't listed, then that's still intussusception. So you got to use your head, all right? Now, once again, midgut volvulus, upper GI series, and this is what we're going to have here. So choice B, absence of enteric ganglion cells, wrong. That's going to be Hirschsprung disease. Classically Down syndrome, but not mandatory. It's failure of neural crest migration distally in the rectum all the way to the internal anal sphincter, absent submucosal and myenteric plexes, absent NO and VIP secreting neurons, which normally relax smooth muscle. So we have increased anal tone, and we have failure to pass meconium in the first 24 hours, which here the patient did that just fine. So that's another reason we know Hirschsprung's wrong. Let alone the image is not what we'd see. The image is going to show you a tapered distal rectum and a transition zone with a dilated, more proximal segment. Okay, now another point of clarification. The phrase Meconium ileus, Meconium refers to the first fecal matter of the neonate. So Meconium ileus specifically is cystic fibrosis, nothing else. It refers to sticky, inspissated, which means dried up within the lumen, sticky inspissated meconium in the ileum, hence the name Meconium ileus. Hirschsprung, although there's failure to pass meconium, we don't call that Meconium ileus. Okay, so that's a pedantic technicality you got to know in terms of the phrasing. And you can, for 2CK step 3, you can do rectal manometry to diagnose Hirschsprung. Wrong fucking answer. Choice C, defective recanalization of the duodenum is fucking wrong. That's going to be duodenal atresia. Okay, so you'd have double bubble sign, abdominal x-ray. Very past level stuff. Also seen with Down syndrome. Bilious vomiting. When we talk about differentials in neonates, the past level stuff, for instance, bilious vomiting, duodenal atresia, or annular pancreas. If we have non-bilious vomiting, projectile, forceful, that's going to be pyloric stenosis. Pyloric stenosis, you do an ultrasound. They'll show you an olive-shaped mass, and duodenal atresia, you're going to do abdominal x-ray showing you the double bubble signs, bilious vomiting. Wrong fucking answer. Choice D, failure of vital induct to obliterate, it's wrong. It's Meckel diverticulum. The rule of twos, so in terms of 2 feet from the ileocecal valve, 2 types of heterotopic mucosa, gastric, pancreatic, which can result in bleeding, iron deficiency anemia. Very important for USMLE that you know that. 2 inches in length. But the age of 2 around that is nonsense / garbage for USMLE. Okay, they'll happily give you Meckel diverticulum in a 19-year-old and soon gets it wrong, thinking, oh, I thought it had to be a kid. It doesn't have to be a kid for Meckel diverticulum. And you do a Meckel scan. It's a radioisotope, a technetium-99 uptake scan to diagnose it. It's a true diverticulum, so it involves all the layers of the GI. So the mucosa, submucosa, muscularis, propria, wrong fucking answer. Choice A, rotational, migrational abnormality of ventral pancreatic blood. Verbose answer choice, me being an asshole, wrong fucking answer. So this is obviously annular pancreas, and similar to duodenal atresia, you'd have a double bubble sign on abdominal x-ray. Wrong fucking answer. You know the deal. I'm 2 make more content. I'm so appreciate your time. That's it.